Good afternoon or good morning, depending on when you are looking at this video. My name is Marie-Pierre Revel. I'm a chest radiologist working at Cochin Hospital, Paris Descartes University in Paris, France. And the topic for today is haemoptysis. It's a very important topic for thoracic emergency because haemoptysis is potentially a life-threatening condition, and the role of radiologist is very important in this topic. I have no disclosures. So these are the learning objectives: to learn about the main causes and mechanisms of massive haemoptysis, to review the role of CT in the assessment of site and cause of bleeding, and to learn about the bronchial artery anatomy assessment on CT. So let's start with some definition. Haemoptysis is a bleeding that originates from the lower respiratory tract. There are various definitions of severity ranging from 100 to 200 milliliters of blood expectorated within 24 hours, but it also depends from the underlying cause and from the patient's cardiopulmonary status. In any case, with severe haemoptysis, the immediate risk is asphyxia and not hypovolema, contrary to other sort of bleeding. Regarding the pathophysiological features, the systemic circulation is involved in the vast majority of cases. It's a bleeding due to bronchial arteries, but also with a potential participation from other systemic arteries like the internal thoracic artery, the intercostal, or the phrenic arteries. And this is the case in patients with bronchiectasis, with chronic necrotizing infections, and with tumors, which release angiogenetic growth factors. But in addition to this predominant cause, the pulmonary arteries are sometimes involved. It was estimated to occur in 10% of patients referred for embolization, and the bleeding is due to false aneurysms or to tumors. Lastly, the aorta is sometimes involved. It is very rare, but usually the bleeding is really catastrophic, and especially when there is a bronchial fistulization of aneurysms or a false aneurysm. And we are going to see cases for all these different features. Last cause is a damage of the alveolar capillary membrane in patients with vasculitis. They present with intra-alveolar hemorrhage, and we can suspect the condition when there is a discrepancy between the abundance of ground glass contrasting with a small volume of expectorated blood. And it's very important to make this distinction because patients with intra-alveolar hemorrhage should not be referred for embolization, of course. So now, what is the role of CT in the assessment of site and cause of bleeding? The first objective is to identify the bleeding site. It's very important because if the bleeding is very massive, the only way to save the patient is to perform a selective intubation, and we have to know if the bleeding comes from the right or from the left lung. And for this, there's a role for chest X-ray. Let's see this case. This patient was admitted after a first episode of bleeding, and while she was hospitalized, she had a recurrence of bleeding. And the chest X-ray taken just after this recurrence of bleeding demonstrated that there was this alveolar opacification in the right upper lobe, meaning that the bleeding was coming from the right lung, and this allowed starting the embolization procedure with the right bronchial arteries. And we evaluated in this paper the role of CT to identify the site of bleeding, and we demonstrated that it was perfectly equivalent to bronchoscopy, with a major advantage for CT, which is the superiority of CT compared to bronchoscopy to identify the cause of bleeding. Non-specific CT findings are helpful to identify the site of bleeding. In this patient, bleeding is coming from the right upper lung because of this ground glass opacification demonstrated here. In this patient, the bleeding comes from the lingula, and in this last case, it's very difficult to find if the bleeding is coming from the right or from the left lung because there are ground glass opacification in both lower lobes. So these ground glass opacities indicate the bleeding site, but only in non-dependent lung areas. Atelectasis is another CT features in patients with severe hemoptysis, and it's due to some blood clots obliterating the proximal bronchi. These non-specific features are sometimes misleading. This patient presented with a severe hemoptysis and this with this upper left lung consolidation that was thought initially to represent a tumor, but it resolved within a 1 week interval, and it was only the consequence of bleeding. So be careful. Do not over-describe these opacities as being potentially of malignant origin. We need to perform short-term CT follow-up to distinguish between opacities which are due to bleeding or opacities of malignant origin. Then the role of CT is very important to identify the cause of bleeding, and the first cause is bronchiectasis, as in this patient here. Second example here, bronchiectasis from the left lower lobe, and in this patient, bronchiectasis and ground glass opacification in the middle lobe. In patients with TB, the typical features are upper lobe consolidation showing some cavitation in acute tuberculosis with a bronchial spread of infection responsible for all these bronchial nodules. But sometimes bleeding occurs in patients with TB sequelae, like in this case, with some nodular calcification and scarring. Tumors, two possible presentation, either an encasement of the blood vessels or some cavitation close to vessels, and the mechanism is probably an erosion of the vessel by this superinfected tumor. In patients with aspergillomas, CT is very superior to chest X-ray, demonstrating this typical fungus ball appearance with this opacity within a pre-existing cavity. And as you can see, it's very difficult to depict this image on the chest X-ray. The crescent air sign is not always obvious. A last but rare cause is catamenial hemoptysis, and I wanted to show this case that we had, very rare, a lady who had 3 episodes of severe catamenial hemoptysis, and she asked for admission at the hospital the day before the 3rd episode, saying, I might expectorate some blood tomorrow, because she experienced 2 preceding episodes, and she was right. She presented a very severe bleeding, and on the chest CT performed just after this bleeding, we demonstrated the presence of ground glass opacification, which resolved within 1 week. In this case, treatment is not embolization, but suppressive hormonal therapy. What is the bleeding source? It's very important to identify which vessels are involved. And it has been clearly mentioned that performing a contrast-enhanced CT before embolization is very important to define the source of hemoptysis as being of bronchial systemic or non-bronchial systemic or of pulmonary arterial origin. The systemic circulation is involved in the vast majority of cases. The reason why when The bleeding is very severe. Patients are directly referred for bronchial embolization, but it's a bet. And I think that in any situation where it's possible, it's better to perform a CT first. This is here a case of a patient treated by my colleague, Professor Khalil from Paris, presenting with a very severe haemoptysis due to this bronchiectasis from the middle lobe, and the patient was successfully treated by right bronchial embolization. Another case, a young patient with aspergillomas. She had a bleeding originating from the thoracic, the internal thoracic artery, and she was successfully treated by embolization. However, the pulmonary circulation is sometimes involved. It's reported to occur in 10% of cases, and mainly in patients with necrotizing infections or tumor. This is the case of a patient with acute TB. You have here a consolidation with some cavitation, and if we pay attention, there is this image which is abnormal. This enhancing structure is not a normal vessel, but a false aneurysm. The patient was referred for bronchial embolization, which was not the good choice. And of course, there was a recurrence of bleeding after the procedure. And on the second CT, we can see that this false aneurysm has increased in size. And then the patient was referred for the right procedure, which was a selective pulmonary angiography, leading to this treatment of by coil embolization of this false aneurysm. Another case in a patient with acute TB, MIP reformation is very useful to depict this round image being due to a false aneurysm. In patients with necrotizing infection, like in this case, Klebsiella pneumonia infection, when you can see all these cavities, my recommendation is to use contrast, even though the patient has not presented any episode of haemoptysis, because in this situation you might depict the presence of false aneurysms, and this allows to preventively treat the patient by selective embolization to avoid a very severe bleeding episode. Sometimes it's difficult. I was asked to determine if this false aneurysm was due to the pulmonary circulation. We cannot see a direct connection between the pulmonary vessels and the false aneurysm, but it's very likely for necrotizing infection, it was a case of acute TB, that it is due to the pulmonary arteries. So the patient was referred for selective pulmonary angiography, but as you can see, no false aneurysm could be depicted. Then she had opacification of the intercostal arteries, no false aneurysms. Of the internal thoracic artery, still no aneurysms. And finally, she had a selective catheterization of the bronchial arteries, and the false aneurysm was fed by the bronchial artery. It's very rare. Usually, false aneurysms are due to injury of the pulmonary arteries, not of bronchial systemic origin, but as you can see, it's sometimes the case. And so this is the initial CT, the CT performed 1 year after, and as you can see, there was a very good evolution in this case. Patients treated for leukemia experience sometimes very severe neutropenia, and this is the condition to develop very invasive fungal infections. So this was the case of a 70-year-old woman, and this is she presented with a fever and a right upper lobe consolidation. Several days after, you can see that there is here a cavitation, which is more obvious on the coronal reformation, but no bleeding. But haemoptysis occurred several days later, and So contrast-enhanced CT was performed, revealing this huge false aneurysm, which was treated by embolization. And this is the follow-up CT, and we used contrast administration, and so my colleagues thought that maybe the embolization had failed. It was not the case. It was only the stagnation of contrast within the false aneurysm. So to control after a follow-up after embolization should be first performed without contrast administration. Another case, a patient evaluated for an undeterminate middle lobe pulmonary nodule, 18 millimeter in diameter, no fat, no speculation, so it's very difficult to decide if it's a benign hamartoma even though there is no fat content, if it's a carcinoid tumor, if it's a lung mets, or if it's a stage 1 lung carcinoma. So we perform a contrast-enhanced study, and on the 30-second CT performed 30 seconds after contrast administration, we can here find out that this is a vascular structure, and it was a false aneurysm from the pulmonary arteries, and the reason was that the patient had a history of Swan-Ganz catheterization, and we know that it can be complicated by haemoptysis when there is an injury by the catheter of the pulmonary arteries. So beware. So to summarize this, the acquired pulmonary artery pseudoaneurysms are mainly of traumatic or infectious origin. In patients with lung cancer, there are two main presentations for pulmonary artery bleeding, either a direct arterial wall invasion or vascular erosion if there is a necrotic cavity, like here. And it's very difficult to treat these cases. Lastly, bleeding coming from the aorta, it's very rare, but it's usually catastrophic. If there is the fistulization of a true aneurysm, such as in this patient, it's usually really a massive bleeding, and it's very difficult to treat the patient. Fortunately, some large aneurysms are prevently treated by stenting, but if there is a leak from this stenting, patients might experience haemoptysis, and it's very difficult to depict the contrast extravasation. So patients with such images presenting with haemoptysis, even though we cannot depict the contrast extravasation, this does not rule out the possibility that it's a bleeding coming from the aneurysm. False aneurysm also occur from the aorta. They are mainly of mycotic or traumatic origin. This is a very impressive case that I had several years ago, and this false aneurysm was fistulizing. The patient had a fistulization in the bronchial system, and it was due to tuberculosis infection. A more recent case, a patient with lung cancer, two different tumors, and probably nodal invasion. So the patient was referred for echoendoscopy, and 1 month later, she presented with a small amount haemoptysis. Fortunately, we performed the CT shortly after this episode, which allowed depicting this huge traumatic false aneurysm. Probably during the echoendoscopy, there was vascular injury of the aorta and causing this large false aneurysm, which was immediately treated by stenting. So last important thing is that CT, contrast-enhanced CT, helps the identification of the bronchial artery anatomy before embolization. And it has been reported, especially in older patients, that the catheterization failure rate is higher if multi-detector CT angiography has not been performed before the embolization, because it helps the identification of ectopic origin from the bronchial arteries. So what is the normal anatomy? The normal anatomy, in 60% of cases, we have one right bronchial artery originating from an intercostal bronchial trunk, like here, and two left bronchial arteries. So this type 1 and type 2 represent 60% of normal cases. More rarely, we have two right bronchial arteries and two left bronchial arteries, and very rarely, type 4, two right bronchial arteries and one single left bronchial artery. Volume rendering is very helpful to demonstrate the bronchial artery anatomy. Here we have an enlarged intercostal bronchial artery, and what is hypertrophied is the bronchial part of this trunk, not the intercostal part. And the right bronchial artery originates from the right aspect of the descending aorta, whereas the left bronchial artery originates from the mid portion of the anterior aspect of the descending aorta at a level corresponding to the left main bronchus. This is the normal origin. But in some patients, we have some ectopic origin of the bronchial artery, especially in this patient. The left bronchial artery originates from the aortic arch, which is not the normal anatomy. And if it is not depicted before embolization, the risk is that the embolization procedure is going to fail. Non-bronchial systemic arteries are also involved in some patients. This is here an enlargement of the intercostal arteries, here of the phrenic arteries. And in some patients, I already shown this example, it comes from the internal thoracic arteries, and in very rarely, but mainly in patients with bronchiectasis, the coronary arteries are involved, and it's very, very dangerous to perform the embolization. We need absolutely to have very selective catheterization because, of course, it's very dangerous to send some material within the coronary arteries. What about the CT acquisition protocol? We need to have an opacification of both the pulmonary and the systemic circulation, and for this we need to use a large amount of contrast, a high injection rate, and with a start delay of approximately 30 seconds. Delayed acquisition is helpful to detect contrast extravasation in aortic aneurysms, and some post-processing techniques are very useful. MIP for the identification of the systemic arteries origin and course, and the detection of false aneurysms. Minimum intensity projections helps the identification of focal ground glass due to bleeding, and volume rendering is interesting to describe the bronchial artery anatomy. So, two examples of MIP reformation. Here, the depiction of a false aneurysm, and here the demonstration of an enlargement of the right bronchial artery on coronal reformation. Minimum intensity projection is interesting for sensitization of focal ground glass detection, as shown here. Of course, we can depict some ground glass opacification, but it's really more obvious with the minimum intensity reformation. Volume rendering is interesting for the description of the bronchial arteries anatomy. And in this patient with bronchiectasis of the left lower lobe, we see that the two left bronchial arteries do not originate from the mid portion of the descending aorta, as usually, but from the right aspect of the descending aorta. And in this patient, volume rendering helps the depiction of this ectopic origin of one of the two left bronchial arteries. So in conclusion, Severe hemoptysis is a medical emergency. The role of CT is very important, of contrast in CT, because it helps localizing the bleeding side, finding the origin as being systemic, pulmonary, or rarely aortic. It helps embolization. It's a road mapping before embolotherapy. And lastly, it helps the identification of the cause of bleeding. Thank you very much for your attention, but before concluding, I have two take-home messages very important. For any necrotizing infections, we should use contrast, and not all bleeding are from systemic origin. The pulmonary circulation, remember that it's involved in 10% of cases. Thank you very much.